of size criteria in the AGCC TNM staging system. She has a lot of publications to his account, and she has played key leadership roles in RSNA as well as ACR. So it's a great pleasure to have you over here, and I think we are going to have an amazing session and learn a lot of important things. So thank you so much, ma'am, for accepting the invitation and being here with us.
Thank you for having me. It's an honor and a pleasure to be part of the Cafe Roentgen seminar, and I hope to kind of come back again at some point and give another talk. Today I'm going to be talking about imaging of the pleura RadPath correlation. I'm going to show you some basic pleural abnormalities to pleural tumors, and we'll go over some of the radiology pathology that is involved with these tumors. Okay, so before I go, I just wanted to kind of share, it's for trainees, it is free to become an STR member. Here's a QR code. Please consider becoming a member of the STR. There is a lot of educational material which is available to members, and a lot of great teaching content which is available on our website. So please look up our website and consider becoming members. These are my disclosures, nothing really pertaining to my current presentation, but I do have some relevant financial relationships that I wanted to declare. So the learning objectives for this talk are to define pleural disease characteristics, go over some of the differential diagnosis of pleural and chest wall tumors, and then describe some primary and malignant masses. We will do RadPath correlations with some of the basic histopathological characteristics. If time permits, we may review some of the chest wall pathologies, which abut the pleura as well. So to start off, pleural pneumothorax, which is a very common thing, which you see in, which is the first thing that we look for in most radiographs in patients presenting with chest pain. So what we are really looking for is pleural reflection, which is a thin white line parallel to the chest wall, and we look for no interstitial markings or no lung markings beyond that pleural line. As you can see here on the left, there's a very nice pleural line defined there. Now, normal pleura, is very hard to see because it is very thin. It's thin, less than 5 millimeters in thickness, and so normally we should not see the pleura. So the only time we see the pleura is whenever there is an abnormality directly or indirectly affecting the pleura. So in this case, for example, there is air which is abutting the pleura, which is why it highlights the pleural reflection, which is why you see it. In cases of pleural effusion, you also see the pleura because the fluid kind of outlines the pleura or extends into the pleural reflections between the visceral and the parietal pleura, causing pleural thickening or pleural outline, and that is why we see the pleura. So on an erect chest X-ray, pneumothorax is that the rises, so the opposite pneumothorax, and also flattening of the diaphragms, and so that's an emergency. You need to kind of very quickly decompress the tension air by putting in a chest tube or a needle. Otherwise, you can lose a patient. So now something to remember that air normally reabsorbs at a rate of approximately 1.25 centimeters per day. So having said that, if somebody has a stable pneumothorax, it's not going to go away in 24 hours. Depending on the size of the pneumothorax, it will take a certain number of days for it to resolve. Now, all of us have been caught off guard by skin folds, especially in older, skinny individuals. You can have loose skin, which can mimic pneumothorax, and very old skin fold as a pneumothorax. So whenever you're in doubt, you think that there is a pneumothorax, but you're not sure, there is a solution. You can do an expiratory radiograph. You ask the patient to breathe out, and then you more obvious. And here's an example. This is a very large pneumothorax, as you can see here. This is inspiratory, expiratory done at the same time, and you can see that the same pneumothorax looks much more conspicuous on the expiratory view. Now, obviously, we do not need to do this when the pneumothorax is pretty obvious, like in this case, viruses or chronic pneumothorax. There's a case of a patient with Burtog-Dubé syndrome, and they had these cysts which continue to rupture, and they actually did a pleurodesis on this patient. And because they did a pleurodesis, there were pleural adhesions that kind of formed. However, before they did the pleurodesis, the pneumothorax had not been completely evacuated, so the air got trapped in different parts of the pleura. So that is a chronic pneumothorax. Now, something like this may never go away or may absorb a little bit but may remain the same. However, it doesn't really even increase. So it remains pretty stable, and sometimes people will mislabel these as emphysematous blebs or cysts. This is a pneumothorax calculator which I got from the web. There are several, I think the chestxray.com website is now, you have to have a membership or a subscription for it, but you can look up a pneumothorax calculator if it is of interest, and you can put in the numbers by measuring the pneumothorax at different parts of the chest. And so if, for example, there was no pneumo at the level C, then you put a value of 0 and you calculate it, and it gives you what percentage the pneumothorax is there and how many days it will take to resolve. And as I mentioned, it resolves at approximately 1.25 centimeters per day, or 1.5% by day. And now this holds true for a stable pneumothorax, but does not really work if a pneumothorax is increasing. But this is a very good guide to tell you when to bring the patient back to ensure that the pneumothorax is completely resolved. So now in terms of pneumothorax points to remember, small if it is at the top in an erect patient. I generally will divide the chest into 3 parts. And my threshold is, because everybody needs to have a threshold, because otherwise you can call everything small or everything large. So if it reaches about the level C, it is still small, like it's small if it is just blunting in terms of an effusion. If it is small in terms of a pneumothorax, if it is small at the apex. And so I divide the chest into 3 parts and kind of use that as a small, moderate, and large categorization to guide as to if a pneumothorax is getting bigger or smaller. The 20% is kind of like, rule of thumb. That's when you really need a chest tube. Those are patients who start desatting. 40% is when you start seeing the lobes of the lungs are getting separated. And tension pneumothorax is when you start seeing shift. It starts to recruit more space and causes shift. And anytime a pneumothorax is there for more than 24 hours, the pleura will start secreting fluid and trying to fill up the empty space. And so it always becomes a hydropneumothorax. Anytime in doubt, do expiratory views to look at the pneumothorax. Now, a word about pleural effusions. If the air is replaced by fluid, 10 ml of pleural fluid is formed every day, and as the lung kind of expands and collapses, it gets reabsorbed into the lymphatics. Most individuals will have between 1 to 5 ml of pleural fluid at all times. You need approximately 75 cc's for blunting of the posterior costophrenic sulci. This shows up on the boards, so remember that. And if you need more than 175 cc's for the lateral costophrenic sulcus on a PA view to be blunted. And then you can detect as little as 25 ml fluid on a lateral decubitus view. So if you you think you're wondering if the patient has a small effusion, you can do a decubitus view. Now that is a very small, pleural effusion. Most of the time, the patients have no symptoms, and it's very, very hard to actually even tap it, and most people won't do anything about it. The first 300 ml will not generally collect in the subpulmonic space, and then it will spill into the pleural space to elevate the hemidiaphragm and displace the peak laterally. The meniscus kind or the positional location, depends where the fluid is. Sometimes you will see that the fluid will, extend into the fissure and form a pseudotumor. It kind of makes looks like a mass on a radiograph. But if you look at it on the lateral, you can see clearly that it takes the shape of the pleura. And I'll show you an example. We generally look for pleural enhancement, which is suggestive of an exudative effusion. Now, an exudative effusion may be malignant or infected, depending on the context of the patient's history. And then we do tend to measure densities on CT, but remember it's not really um, a very reliable indicator to figure out if it is transudate versus exudate. Some people have even tried to measure the density to predict if it was a chylous effusion or not. In this day and in this day and age, because we do play with the KVP, and we have a lot of different filters and different technologies to reduce radiation dose reduction. So the Hansfield units can be very variable, especially so on the photon counting CTs. The large effusion post-surgery, if somebody's developed suddenly a very large effusion, which has accumulated in a matter of seconds, post-surgery, if it is on the right side, suspect chylothorax, especially if it was a right lower lobe resection or esophagectomy or so. Also hemothorax, either side, is of concern if the crit is dropped. Vacuothorax, which is a trapped lung, which can be seen post-thoracentesis, and this happens due to non-expansion of the collapsed lung due to adhesions or tumor. So this is a very large effusion, and you can see that this is a lateral decubitus view. And as I mentioned, that this is very sensitive for very small amounts of fluid. You can see as little as 25 cc's of fluid. Very small amount of fluid. If you're thinking of tapping, you generally want to do an ultrasound guided tap. And we do decubitus views to look for layering of the effusion. Is it loculated or not loculated? This is a chest X-ray and CT scans post line placement. You can see immediately there was a whiteout. You can also see that there is shift of the mediastinum to the opposite side. And then there's a line with a curvilinear path, which looks very abnormal. And on CT, you can see that the line is actually traversing through the lung parenchyma and ending up in the SVC. So the first instinct whenever if you were putting in the line, is always to yank the line. And I tell people is that you have to curb the urge from, pulling the line out, because in your instinct, you think that this is in an abnormal place and you want to take it out. But what very often happens is that it is actually plugging the hole that is causing the bleeding. And so if you pull the line out, then the patient may have even more severe bleeding. So you do want to consult IR and maybe put in a stent over or coils over the area with the bleeding. Here's an example for a pseudotumor, which looks very mass-like, but whenever you do a lateral, you can see that it takes the shape of the pleura, and this is indeed fluid trapped within the two pleural surfaces, and so this is a pseudotumor or just trapped pleural effusion. Here's an example of a trapped vacuothorax. The patient had a chylus leak, which was there for a few days. And as they put in a chest tube and evacuated the effusion, there's no fluid here. There's a large pneumothorax, but you can see that the lung is not re-expanding. And this often happens if there are adhesions, either from tumor or infection. In this case, it was from chronicity, the lung was trapped. This was a very large effusion from a chylus or a thoracic duct injury, and the endothoracic duct embolization was performed. Two examples here. One is an effusion, one is a collapse, and you both have whiteout, and I want to show you the side by side. And you can see in this case, there's a complete whiteout of the left lung, but you see that the shift of the mediastinum is to the same side. So that means the heart and the mediastinum is shifted to the left, and you can also see that an ET tube projects to the right mainstem bronchus. So this is complete collapse of the left lung. In contrast, here you can see there's complete opacification of the right lung or the right hemithorax, but the mediastinum shift is to the opposite side. So this is a very large pleural effusion from an abnormal or an iatrogenic injury to the lung from a line placement. These are MR images, T1 post-contrast and T2 weighted images showing you a very large exudative effusion. Sometimes it can be incredibly hard, depending on the timing of the scan, to see contrast enhancement on a CT scan, but on MR, because the superior contrast to noise ratio, you can actually see the enhancement much nicely. Loculated effusions on CT, and this is the split pleura sign here at the bottom, which is what you look for in empyemas. Again, there's a lot of pleural thickening, and it's multiloculated, so this is an exudative complex pleural effusion. Again, looking at this, all you can really say is this is exudative. Is this tumor? Is this infection? Will depend on cytology. There have been several publications which have used MRI to distinguish benign from malignant effusions. Certainly, like you do the regular T1, T2, and post-contrast images, and you look at enhancement and you also look for any ancillary findings such as tumors or any masses anywhere to see if there is there's this related tumor or infection. The clinical information is key in that case. If the white count is up, that it may be more likely to be infection rather than tumor. There's a lot of work ongoing in which people have used ADC, quantitative ADC values, to differentiate benign from transudative, from exudative effusions. And if you know the ADC value of a tumor, you can also correlate the effusion or the lesion to a certain histopathology. Asbestos gives you asbestos related. There are several things asbestos exposure can do. When there is very small amounts of asbestos exposure, it generally is not noticeable. Patients have no symptoms, and there is an latency period of 20 to 30 years before people develop cancers. The most common cancer that is associated with asbestos is lung cancer, but there's also a very high incidence of mesothelioma, which is related to asbestos exposure. Now, asbestos exposure can also give you what you see here are called pleural plaques, and the asbestos gets deposited in the pleura, and it may give you calcified or non-calcified pleural plaques, which look very bizarre on X-rays. But if you look at the lateral radiograph, you will see that they actually take the shape of the pleura. Now, if the asbestos exposure is even higher, it can also give you an interstitial lung disease called asbestosis. Now, asbestosis and asbestos related plaques can coexist, and there is no real chance that, there is no guarantee that asbestos related plaques may progress to asbestosis. They can exist independently as well. Round atelectasis, this is a complication of pleural thickening. So, when anytime there is a pleural injury or pleural abnormality, in this case, there's pleural thickening and there's a pleural plaque as well. The part of the lung in this area gets trapped and has adhesions around it and forms what is called as round atelectasis. They can mimic as masses anytime you look at this. Obviously, in a patient with asbestos exposure, there is concern that this may be a lung cancer. And so sometimes people will suggest to do PET CTs, but something to remember that if you do a PET CT, the SUV of atelectasis and an early lung cancer can be very similar. They can both be in the 3 maximum SUV values can range between 2.5 to 3 for atelectasis, as well as some of these mucinous or lipidic and or slow growing adenocarcinomas. And so that really doesn't really help you. So what can really help is sometimes watching these on a longitudinal at a time within, every 6 to 12 months to see if any part of that area is growing or getting bigger. But the most important thing is to kind of remember that you will have round atelectasis whenever you have pleural thickening. This is an example of a fibrothorax, and this is a treatment which is very commonly done for tuberculosis. Very rare to see this these days, but every now and then you will see an older individual come for an X-ray, and you do an X-ray and you look at these bubble-like lucencies in the pleural space, and you're wondering what is this? So these are leucite balls which were actually put in patients who had tuberculous pleural effusions to collapse or kind of create a fibrothorax as a matter of treatment for TB. So this was done for tuberculosis. So to wrap it up, remember if there's unilateral pleural thickening or pleural calcifications, it's always related to trauma or prior granulomatous disease. If it is bilateral, then it is related to asbestos. Now, asbestos-related pleural plaques will spare the apices and the costophrenic sulci. So anytime you see that in those areas involved, it is invariably not asbestos. So what are the characteristics is moving along to pleural masses? So what are the characteristics of a pleural mass? You will see obtuse angles with the pleural surface. And you see sharp margins of the mass on a tangential view. And if you looked at the same mass on on a PA and a lateral view, you'll see that they don't look the same. And that is how we distinguish a pleural tumor or a pleural mass from an intraparenchymal mass. One border is always incomplete and it can cross sutures. So you always also look for other ancillary findings such as osseous or soft tissue or chest wall in thickening. So here's an example. You can see that the one margin kind of fades into the chest, and it has obtuse margins with the lung. And then on the lateral, see how it looks so different from the AP view or the PA view. It takes the shape of the pleura. So it's either going to get elongated like this, or it'll get elongated like this because it's arising from the pleura. The WHO histological classification of pleural tumors, it is there's a very long list. There are mesothelial tumors, there are mesenchymal tumors, and there are lymphoproliferative disorders which involve the pleura. Among the mesothelial tumors, mesothelioma is one of the largest ones to think of. The true incidence of mesothelioma in India seems to be poorly understood, and there is a lot of work that is ongoing to define the epidemiology of mesothelioma in India. Among the lymphoproliferative disorders, you can either have a primary lymphoma, which can arise de novo from the pleura, and most of these patients have pyothorax initially, or have empyemas, which then change into lymphomas. Or you can have a lymphoma with secondary involvement of the pleura, which is relatively rare. Among the mesenchymal tumors, there are angiosarcomas, hemangioendotheliomas, synovial sarcoma, and fibrous tumors of the pleura. They have undergone a lot of different nomenclature change. Initially, they were used to be thought to be as benign mesotheliomas. Later on, the nomenclature involved to call them solitary fibrous tumors. Currently, now, since we understand them better, we no longer call them solitary, we just call them fibrous tumors of the pleura. And they can be multiple, and they can be benign and malignant. And then again, there are some rare tumors as well. So let's review some of these tumors. Lipoma, it's a very commonly encountered benign tumor of the pleura. Very often, the patient gets an X-ray for something, and we see this pleural abnormality. We worry about a Pancoast tumor or some other pleural tumor, and the patient will get a CT scan, and you will see very nice fat attenuation, completely black pleural lesion without any fat stranding or enhancement or any septations. This is a benign lipoma. It can have septations, and if sometimes a patient keeps feeling the lipoma and they keep trying to touch it, and you can have inflammation. And if you end up doing a PET CT for something like this, you can see a little bit of uptake, or you can see enhancement post contrast. But that shouldn't throw you off. Anytime you see the Hounsfield units it's homogeneously black like this, then this is a benign lipoma. They can change in size based on the change in weight of the patient. If the patient gains weight, the lipomas can also grow. Fibrous tumor, these are, they patients may have no symptoms, uh, or they may present with some vague symptoms such as chest pain, cough, which may be truly unrelated to the lesion. And they get an X-ray, and that's how we find the lesion. But about 10% of these patients can have hypoglycemia, and another 10% of these patients can present with paraneoplastic syndromes. What is in the paraneoplastic syndromes? You can have clubbing, you can have hypertrophic osteoarthropathy, or you can have hypoglycemias. 80% of these arise from the visceral pleura, and 20% of them arise from the parietal pleura. They are generally well encapsulated and pedunculated. So if it's a very small fibrous tumor, the way we used to diagnose it before CT was so heavily available was we would ask the patient to lie in a decubitus fashion or prone, and you will see that they moved, and that was one of the ways we would tell that this uh, was uh, was a fibrous tumor. They can have a nodular or whorled appearance. The CD34 is the immunohistochemistry marker, which which confirms that this is indeed a fibrous tumor. The calretinin and WT1, these are markers for mesothelioma. So focal mesothelioma can mimic a fibrous tumor, and so this is a way to differentiate histologically as to what this tumor is. And most often the immunohistochemistry is the best way to differentiate different tumors from each other. They can have hemorrhage, necrosis, and cystic degeneration. So let's review an example here. So here's a mass which is seen in the right lower chest here. On CT, you can see that this has a broad base to the pleura. It's very homogeneous. There is no fat or calcification within it. Here's another example in which you see this patient actually was from Cyprus, and she had she was moving to the United States. She was a researcher moving to the United States, and she needed an immigration checkup. And they did an X-ray, and they found these two well-defined lobed, kind of like round lesions in her chest. Now, Cyprus, as some of you know, is endemic for hydatid cysticercosis, and so there was a big suspicion that these, because they were so round and they had these areas of calcification, that they may be hydatid cysts. So she got a CT scan done, and even on CT, you can see that there are two of them. One is there's two masses. One is a bilobed mass sitting in the pleura here, which has areas of calcification. And then the second mass, which is more medial here and posterior, you can see that it actually widens the intervertebral foramina there, and is trying to extend into the nerve there. And that's where the patient was actually having chronic back pain. So the surgeon took her to the OR, and they opened and they closed her. And then many years she came to United States, and she got this radiograph. And you can see that it's a very confusing picture, because it's one, it is not solitary. Two, this one is pleural based, but then this one is in the fissure, which is technically also pleural based. But could these be infected, hydatid, or could this be fibrous tumor of the pleura? So she got an MRI done, and you can see on the MR that this is T1 dark and T2 dark. So that tells you this is fibrous tissue. And then on post contrast, it enhances very homogeneously. The posterior mass doesn't have enhancement, it has a septation. But by just looking at this, the imaging characteristics on MRI, you can pinpoint that this is indeed fibrous tissue. And if we had delayed imaging, fibrous tissue also tends to retain gadolinium post contrast on a delayed for up to 5 to 7 minutes. And so if you get delayed images, you can also see that it will retain contrast. And so these were all fibrous tumors of the pleura. Now, there is also an entity called as malignant fibrous tumor. They look very similar on CT. And you can see that there are multiple lesions, and they can metastasize like any tumor. They actually behave like sarcomas. On MR, the main difference is that on T1 they're dark, and on T2 they're bright. Fibrous tumors tend to not have any uptake on PET-CT, but the malignant fibrous tumors tend to have uptake on PET-CT. And then again, on MRI, they certainly are T2 bright. There are a lot of edema, and then, they show heterogeneous enhancement post-contrast. Uh, DWI or ADC is a very good way to figure out if there is malignant degeneration. And so if you have a baseline tumor in which, suppose this is a very large tumor, which was also a known fibrous tumor of the pleura, the patient did not want to have surgery. And so they tracked the patient over time, and we found that the ADC values over time kind of on some areas start to change, and there was malignant transformation in the fibrous tumor. So there is a small entity of fibrous tumors of the pleura which tend to have um, which tend to change into liposarcomas. And so, if, diffusion can really be helpful in those cases. Moving on to liposarcoma, these can be metastatic, or they can arise de novo from the pleura. And there's no evidence to suggest that lipomas change into liposarcomas, but there is a small subset of fibrous tumors of the pleura which can undergo liposarcomatous transformation, but the lipomas do not transform into liposarcoma. These tend to be heterogeneous masses on CT with a soft tissue and fat component. They tend to measure less than 50 Hounsfield units on CT, and they can have pre and post contrast enhancement. There are 7 different subtypes of liposarcoma, starting from well differentiated to poorly differentiated to myxomatous liposarcomas. And depending on what type of liposarcoma it is, the solid component will vary. On MRI, they tend to have high signal intensity on T2 weighted images because of myxoid degeneration, and can have variable gadolinium enhancement depending on what subtype it is and how much of the soft tissue component it is. Even on pathology, they can look very, very similar to benign lipomas, and immunocytochemistry may be needed to differentiate the two, especially in very well differentiated liposarcomas. In patients which have soft tissue component, as you can see here, mixed component, there's a pure fat component, and then the areas which have solid component, which tend to have a much more pleomorphism, and they are the more aggressive component. Synovial sarcoma is another tumor which tends to arise from the pleura. It is seen in adolescents, in young adults between the ages of 15 and 40 years of age. It tends to have a bimodal peak, and even though it's seen in very young individuals, you can see a second peak in the 40s. They are believed to originate from primitive pluripotent mesenchymal cells, which are capable of synovial differentiation, even though we don't have synovial tissue in the pleura, but the mesenchymal tissue can transform into synovial differentiation, leading on to synovial tumors. Because of its rarity, it is often mistaken to be a sarcomatoid mesothelioma. These are tumors which you see the triple sign on MR. You can see all 3 elements you can have. They can be bright, ISO, or hypointense on T1 weighted images. They tend to be focally positive for EMA and E1 and E through. Again, the FISH, which is cytogenetics, which is done to look for the SYT gene rearrangement. The main thing that you want to differentiate it is the fibrous tumor of the pleura, and also the sarcomatoid mesothelioma. Again, the S100 is for the S100 and CD34 are markers that you will see with fibrous tumors, and then the other tumors which can be seen with other markers which can be seen with mesothelioma are also often run on these tumors. Here's an example of a synovial sarcoma, and you can see T1 dark, and on T2 you have all three elements, which is called the triple sign on MRI, and then the solid component tends to enhance more so than the cystic component. You can see more than one areas which may involve the pleura. You can also see associated pleural effusions in these patients. In later stages, they may metastasize to the contralateral pleura or the contralateral lung as well. Lymphoma, very rare to see de novo pleural lymphoma. In general, the pleura gets secondarily involved if there is mediastinal tumor or there's marrow involvement by the lymphoma, and then the tumor extends through the bone into the adjacent pleura. Now, you can have a pleural lymphoma arise de novo after from irritation secondary to chronic irritation from an empyema. Both primary and secondary forms can involve the pleura, and the most common pleural tumors tend to be follicular and B-cell lymphomas. You can have associated adenopathy, and they tend to be low because they are also more fibrous tissue. They are dark on T1, dark on T2, and then they tend to enhance pretty avidly and uniformly on post-contrast. And you can see here ADC maps and high B value maps also showing you a marrow abnormality within the bone as well, and then pleural tumor, and then there's chest wall invasion, which is much more subtle on the post-contrast images, much more easier to see on the post-contrast images and the high B value images. Lymphoma tends to show diffuse soft tissue enhancement. Anytime you're trying to diagnose a lymphoma, you often need much more tissue because they'd like to run an array of immunohistochemistry markers. One thing to remember anytime we biopsy pleural lesions, and if lymphoma or any lung lesions and lymphomas in the differential, we always put the specimen or at least part of the specimen in saline so that they can run electrophoresis on these patients because that's what helps you differentiate what type of lymphoma it is and also if it is a lymphoma or not, because very often thymomas can look very similar to lymphomas as well. And some round cell tumors such as carcinoids can also, in small cell tumors, can also mimic lymphoma on biopsy because small cell also gives you crush artifact, and so does B cell lymphoma. So, and they both have small round cells, and they can look very, very similar on pathology. Here's a patient who was having CTs for melanoma surveillance, and they found that there was a pleural-based lesion, which was stable, but initially thought to be maybe a pleural-based metastasis from his melanoma, but it wasn't really changing over time, and you can see that it's a very broad-based to the diaphragmatic surface of the pleura. On MRI, this is an EOVIST scan, and you can see that post-EOVIST, this lesion starts enhancing over time. And so this is not a tumor, but just focal pleural focal liver herniation through a gap in the pleura, which was mimicking a tumor. So on imaging, very important to remember where the lesion is, what are its characteristics, and then choosing the right test to trying to figure out what its etiology may be. Malignant pleural tumor, malignant pleural mesothelioma. This is a relatively rare tumor. Approximately 3,000 cases are reported in the US annually. The biggest precursor for malignant pleural mesothelioma is asbestos. The nomenclature of pleural mesothelioma was changed, and it is no longer called as malignant. It is only referred to as pleural mesothelioma. And the reason for that is that all pleural mesotheliomas are malignant. And so, we really don't need to use the word malignant anymore, but refer to them as pleural mesothelioma. As I explained before, that the fibrous tumors were initially referred to as benign mesotheliomas, but they more uh, in-depth analysis has actually revealed that even benign fibrous tumors, or what are referred to as benign fibrous tumors, can locally recur and also give you metastasis. And the prognosis is dependent on the mitosis within those tumors. The malignant fibrous tumors, obviously, they will recur. They tend to be very aggressive and almost behave like sarcomas. The pleural mesotheliomas, on the other hand, is a long latency period. There's 60 people who get exposed to asbestos and also smoke are 60 times more likely to develop lung cancer when compared to non-smoking, non-asbestos exposed people. Pleural mesothelioma tends to occur much more commonly in men as opposed to women, and the latency period is about 40 years. And as I mentioned, that it is a rare tumor in the United States. We see approximately about 3,000 cases a year. Patients will present with usual shortness of breath, chest pain, cough, and weight loss. They can have SVC syndrome or Horner syndrome. They will also have HPO, hypertrophic pulmonary osteoarthropathy or clubbing. There are two different types of mesothelioma. You can actually see it may present as small pleural nodules, which may stud the lung, or it may have a circumferential rind-like pleural thickening, which extends along all the different surfaces of the pleura. Very early on, mesothelioma presents as a pleural effusion, and as time passes, it starts becoming associated with nodular pleural thickening. In the early stages, very often people will mistake it for empyema or benign chronic effusions. And you can see calcified pleural plaques associated with it. And then, as the tumor gets bigger, you can have associated pleural thickening. It can invade. This is one tumor which has the propensity to invade multiple pleural reflections or multiple organs at the same time. And the most prognostic or the most important thing to think about is the tumor confined to the chest, or has it invaded into the diaphragm or into the chest wall, because those are the two key things which will determine if it is resectable or not. In late stages, especially in biphasic and sarcomatoid tumors, you can have pulmonary and lymph node and liver metastasis like any tumors. So this is a very early tumor in which you can see most of it is just pleural effusion, and then there is some pleural nodularity or studding. And as time passes, the effusion starts getting smaller, and the thickening starts increasing, and the thickening will also extend along the mediastinal surface of the pleura, along the fissures, and also along the diaphragmatic surfaces of the pleura. And as the time passes by, the effusion completely vanish, and all that you may see is just a thicker cloud, which may be nodular, could be very orange, very circumferential, or it may be focal. So when I think about mesothelioma, I relate to it as the rind of an orange. And as you know, that there are different types of oranges, and so the different types of mesothelioma, and the rind may be very thin, or it may be thick, or it may be irregular in certain areas. And so that is one of the best ways to remember that is what mesothelioma is. So sometimes when as time passes, the rind doesn't seem to be getting much thicker, but you will see that the chest itself is shrinking. And so if you compare the right side to the left side, you can see that this is very, very much contracted on the right side. Even though the tumor doesn't seem to be very bulky, the tumor here seems to be much more bulkier than in this patient. So anytime when they have this contracted appearance of the chest, this means that the tumor has infiltrated into the intercostal spaces and has caused desmoplastic reaction or contraction. Anytime this happens, This tumor will not be resectable. It's very, very hard for the surgeon to take it out because it has these tentacles going into diffusely into the intercostal spaces, or the endothoracic fascia is diffusely invaded in those patients. Just an example of extensive lymph involvement, liver involvement, and also lung involvement in these tumors. Early on, several studies were done which compared CT versus MRI to see if we could predict tumor involvement, or see if these patients could be resected. And they found that MRI, CT are trying to determine resectability. MR is also helpful in mapping perfusion parameters, and also looking at diffusion or ADC values throughout the tumor. And then the ADC values can be correlated with histopathology. And this, not just for mesothelioma, but if you know the ADC value of a tumor, you can use diffusion as an imaging biomarker, or as a virtual biopsy to figure out what tumor that is. Now, in order for diffusion to work, you need quantitative diffusion, and for that, you need at least a minimum of 3, ideally 5 to 7 B values to get a very reliable or reproducible ADC map. Another, MR images showing you different distributions of the enhancement. You can see that there's an apical area of pleural thickening, but there's also discontinuous areas of pleural thickening extending along the fissures, diaphragmatic surface of the pleura. This was an early mesothelioma. MR can also be very useful anytime we are wondering if this is direct invasion of the vessels. And you can see here that the extensive soft plaque or soft mural thrombus within the aorta is inseparable from the adjacent tumor. And you can see that that indeed was not tumor invading into the aorta, but was abutting the aorta. And the area which looks very abnormal is actually soft plaque within the aortic lumen. However, this patient was not resectable because there were areas of occult chest wall invasion which were not that well seen on the CT scan. This is frank chest wall invasion. In a case like this, a surgeon may resect this tumor and actually take 1 or more ribs with the tumor. And so this is, this is not unresectable. So whenever we're talking about resectability in mesothelioma, things that will make it unresectable are diffuse chest wall invasion, multifocal endothoracic facial invasion, or transdiaphragmatic extension, or direct mediastinal invasion. Focal chest wall invasion, at 1 or 2 ribs, it generally can be resected, and the surgeon may choose to take extensive chest wall along with and block muscle and ribs in these patients. Now, the prognosis is not that great, but if there is no other option available for a patient, then and a patient is relatively good performance status, or a young patient, these can be done to prolong survival. One thing that we've seen in patients with mesothelioma is that tumor volume tends to help with prognosis. So if it was a small volume tumor and just invading a single focus of chest wall like that, and the tumor volume was less than 500, those patients can have very good prognosis. And so in those cases, the surgeon may decide to remove it. And so what I recommend for radiologists is to be descriptive in these patients and detail out where all the invasion is, unless and until there is transdiaphragmatic extension, as is in this case, which is definitely not resectable. In the interest of time, I'm going to move along. We've seen that ADC values can help differentiate different subtypes of mesothelioma. And again, the ADC, you need to get a quantitative ADC value, and you can put ROIs on different parts of the tumor and get average ADC values, and tell if this is an epithelial versus a biphasic tumor or a sarcomatoid tumor. The ADC and the perfusion parameters can also be used to direct biopsies in patients in which initial biopsies are inconclusive. As you can see in this case, this is a biphasic mesothelioma. The red areas are the sarcomatoid part, and the green areas are the epithelioid component. Very often, some of these patients tend to have asbestos-related fibrosis, and when people are biopsying, these tumors may end up in a non-tumor area, and so imaging can also help guide biopsies. This is the ninth edition of the AJCC pleural mesotheliomas T staging, which was recently updated to include a size cutoff for T1 to T3 categories. And we included a tumor size of less than 12 millimeters for T1 tumors without any fissural involvement. T2 when the tumor was greater than 12 millimeters with fissural involvement, or less than 30 millimeters. Anything which is greater than 30 millimeters with fissural involvement or mediastinal fat invasion or a solitary focal area of chest wall invasion was T3. Any other invasion with any size was considered a T4. Some examples on how we calculate the size for mesothelioma. And you can see here that we divide the chest into 3 equal parts by drawing a line at the top of the aortic arch, and then another line at the level of the left atrium, and we get 3 equal parts of the chest. And we measure the most reproducible maximum pleural thickening in each of these 3 parts and add it up to get a P sum, which is then, if you are more than 12 millimeters but less than 30 millimeters, you are in the T2 category. If it is more than 30 millimeters, then you are in the T3 category. If it is less than 12 millimeters and the tumor in the fissure, as is seen in this case, then that would be a T1. We measure the fissure on the lateral or the sagittal view, and you measure the maximum thickness, whichever is the area of maximum thickness, and use that as Fmax or fissural involvement. Anytime the fissure is measuring more than 5 millimeters, it is considered involved. So here's some examples. Here's a CT2 tumor. You can see that this is 15 millimeters, but there is no fissural involvement. This is more than 30 millimeters, and this is T3. Here's a tumor which is directly invading, is about 30 millimeters, but then is invading the chest wall. So this is a T4 tumor. As ipsilateral nodes are N1, ipsilateral mediastinal, ipsilateral hilar, including pericardial and internal mammary lymph nodes are all considered N1. Contralateral lymph nodes, which is which once it crosses the midline is an N2 lymph node, and then any distal lymph nodes, supraclavicular and so forth, are or outside the chest would be an N3 lymph node. This is a tumor which is directly invading the mediastinum, and so this is mediastinal fat invasion or direct mediastinal invasion, diffuse chest wall invasion, direct chest wall tumor. Rounding it off, the most common involvement by any tumor in the pleura is metastasis, and majority of these tend to be bronchogenic carcinoma, followed by breast cancer, and then followed by other entities such as thymomas, carcinomas, and sarcomas. Very often, if somebody has had extensive trauma to the spleen and there's diaphragmatic rupture, you can end up having splenosis into the pleura. The metastases tend to have the same characteristics as the primary tumor, and so it's important to know what patient's tumor was. Thymomas tend to have drop metastasis to the pleura. Osteosarcoma, they tend to create bone formation. You can see that this is diffuse bone formation within the pleural tumor here. And with that, I will pause to take questions. Here is my email. Feel